This is a calcaneus foot where we call when there is a dysfunction of the tender Achilles, when the patient is made to ask to stand up or stand on the toes, the side which is affected, they will not be able to stand. So we have excess of loading on that part of the heel when he is standing and he is walking. A varus foot is because of the peroneus muscle dysfunction, where the patient are prone to have ulcers, impending ulcers on the lateral part, and this is the static pedobaragraph which is showing there is excess loading on the lateral side. And that is a dynamic picture. Clawing also is quite common. It is seen, the treatment is more or less similar for the diabetic patients also. We extend the treatment to diabetics also. The patients who have significant peripheral neuropathy, if they are using slippers without back straps, they tend to hold the slippers from falling off by flexing the toes, and they develop a clawing. And most of the patients who are coming with toe ulcers, we evaluate and we see that they have excessive loading on the toe area. Now we go to the treatment. So the evaluation of the patient is over. So we try to see what is the dominant reason for the ulcer, whether it is the tendon dysfunction, whether it is because of the pressure overload, and whether the bone as such is being altered. So the treatment is distributed in that way. So we do treat them medically. So the treatment initially we give is the vitamin B12. We expect that it will do some good, but in leprosy it doesn't do good. Bisphosphonate is supposed to do some good in Charcot arthropathy because bisphosphonate inhibits osteoclastic activity. So it is being proven that bisphosphonate does have a role in controlling the Charcot arthropathy. Wound care, we have a lot of local application treatment aspects. The second treatment modality is orthotics. So we give orthotics based on the previous pedoparographic study. After giving the orthotics, again we put them back into the pedoparography, see how the pressure overloading and the pressure distribution is taking place. Then again we adjust the footwear, again we put him back. So it takes a lot of time for us to correctly tell that this footwear, if you wear, you are going to be ulcer free for at least some period of time. And we have an orthotic and prosthetic department attached to the leprosy hospital. Now we go to the surgical treatment. This is what I have been doing and I am doing for this. So I put it in this way. We think of an ulcer, when you see an ulcer, we think what we can do to correct them. So we use multiple modalities. For to explain, I put it in different headings. So we do a tarsal tunnel release. This was something which I picked up from diabetic ulcers. So, but in leprosy, this is not that useful. We have done around 30 cases of tarsal tunnel release in leprosy patients. We have done a nerve conduction study before, later. All of them have no snap, no camp, but there's no difference. But patients say symptomatically they are better. I don't know. So we have stopped doing tarsal tunnel release for the patients who are more than 2 to 5 years following leprosy. But it is said to have a definite role in neurotic stage or when there is nerve abscess, because it is just releasing decompressing the nerve. Now we go on to the ulcer management, how we treat the ulcers. I have divided in different areas. So I have taken the toe ulcer. The primary thing is all about debridement. We remove the tissues which we feel is not good. There is no point in keeping any tissue there, so we radically debride. And if you see here, it is exposing the tendon. I don't have a great photograph, but we have found out that her IP joint is not stable. Every time she walks, the IP joint comes and touches the ground. That is the reason why she is developing some sort of ulcer on the toe area, the interphalangeal joint area. So we plicated the tendon and the joint and did a flap cover. And that is the flap which we have taken. It is a random flap which you take it, and this area is grafted off. Now this is the commonest area of ulcer, where the patient comes with an ulcer on the great toe metatarsalphalangeal area. And that what you are seeing is the medial plantar artery flap. We have arteries which is coming on the medial side, which is the medial plantar artery. We have a lateral plantar artery. We have a calcaneal artery on both sides. So based on this, we can take fasciocutaneous flaps. So this patient we debrided, and then we pushed a medial plantar artery flap. And the patient was all right. He went on, and we did his pedoparograph. If you see here, we have given a modified footwear. We found out that there is excess of loading in the metatarsal area. So we gave a metatarsal bar so that he'll not have a recurrence of the ulcer. But he went back. He was happy for 6 months. Then again he went back. His footwear got disturbed. So he said, I did not walk now because I was okay. So I started walking barefooted again. So he came back with a bigger ulcer. So you can see that plantar artery flap there. So we can't leave him now. So we did something like this, which is a Romberg flap. We transfer the tissue to the weight bearing area and see where the loading is less. No, there we can put grafts. So that is the final picture for him. I keep praying that he does not come back with another ulcer. So we strictly tell him that if you are out of the footwear, don't come back to Father Muller's. This is a patient who has got a similar ulcer, more onto the lateral side. But if you see here, this foot has gone for a hallus valgus. That is a radiological picture of the hallus valgus. And what we did is very simple. We just debrided the joint and did an arthrodesis and straightened, and I had done a tarsal release. That is the picture of the tarsal release. And after that, you can see that the ulcer is almost healed. And we did a pedobarography, seeing that there is no excess pressure loading on that area, and we are given a modified footwear. We do get patients in the late stages where their foot has already been amputated and we have an ulcer there which has been persisting for years. Most of the patients have been having ulcers for 6 years, 10 years like that. And what we see is that how we can cover this whole area. Now I have elevated a plantar artery flap. That is what you have to show that this is the abductor hallucis muscle. The whole flap is pushed up and the area which is not bearing weight is being left behind, and which you have grafted, and that is the early picture of him. And he is after 6 months. His foot looks beautiful for me, but not for everybody. So as you move on, now you have another area where you constantly get pressure ulcers, something like this. So inside the foot we have the first layer of the foot with the abductor hallucis, the abductor digiti minimi and the flexor digitorum brevis, which can be used as muscle flaps to cover the defects. It is not equivalent to the fat area, but it's something which best alternative which you can use. So for him, we use the flexor hallucis brevis muscle, flipped back, and then we have covered it with a graft. And this is the same story it happened. Again, he came back with a bigger ulcer. So we did something called as the local fasciocutaneous flap based on the lateral calcaneal artery, flipped it across because we want good skin at this point where he is having maximum pressure. And that is the initial picture, and that is how once the wound has healed fully, the flap is taken up, and this area is not going to have any pressure, or we take care that this doesn't take up any pressure at all. So we give him a footwear with a lateral raise. Then we put him onto the pedobarography. This is the pedobarographic picture that is going on. We make him walk without footwear, and you can see that this is the right side, which is still there is a loading there. So we give a footwear and we try to shift the weight from the lateral side to the medial side. Some of the patients come in at this stage when they they neglect the ulcer and it goes for significant tissue necrosis. Secondary infection also add to the wound. And these are the cases which goes for amputations. And sometimes I do get patients like this who they say that before amputating, why don't you get an opinion from Dr. Latish, because he is the microvascular surgeon, something he'll do. So luckily for him, what I found out that this vessel, the flow was very good for the foot. Whenever there is a good flow, I'm happy. So this is what we did. We took an anterolateral thigh flap. This is a free flap microsurgical technique where you harvest an anterolateral thigh area, tissue from the thigh, and you take it with the blood vessel connected to the posterior tibial artery, and that is the result. Now we get full coverage of the defect right from the medial side up to the lateralmost area, and this patient has done well. We do get patients like this. The patient who has been treated for nearly 4 years, he's got a significant ulcer on the heel, it's quite big, pouring discharge. We took an X-ray, we saw that the patient has got a pathological fracture of the calcaneum, and the tissue, the defect is directly communicating with the bone. That is an MRI picture with the contrast showing us that the infection has spread all over to the calcaneum. What we do is the thorough debridement. That is what is the mainstay of treatment for any ulcer, I think. The conservative line is gone now. So as far as possible, we thoroughly debride, remove all the soft tissues which are there, which is infected and unhealthy. And I put a bone cement there to fill up the gap. That's the bone cement you see there. And that is X-ray. This area is the bone cement. And I applied the same microvascular principle for him. We harvested the right thigh, anterolateral thigh flap. And that is the picture for him. So we have replaced the whole of the heel area with a flap which is taken from the anterolateral thigh. This was initially taken as an inside site. The main problem with people say is that this is insensate. But what we have done is we have taken the femoral cutaneous nerve of thigh also with that and connected to the posterior tibial nerve. And he says that he gets sensation, but it is still in the red zone. But definitely if you touch him, he is there now. What? He says, I am getting sensation. And initially it is bulky. Definitely the flap will be bulky because some patients are bulky patients. And you need to do some sort of flap thinning. So this is now for a flap thinning. After 6 months we have taken up. And this will be the picture. So from an area where you have a diabetic ulcer which has been significantly there, we have been able to replace it and there is no infection, no ulcer. Now I go from the ulcer to the tendon transfer. The treatment for this patients is multifactorial. We combine procedures, but I am going by step. Whenever you get a patient with claw deformity, we say that there is a problem in intrinsic function. So we try to correct the claw deformity by transferring the flexor, the digitoral longus tendon to the extensor. I don't have a photograph to show that clinically. When the patient comes with the varus foot because of the peroneal dysfunction, in this case, they are prone for ulcer on the lateral aspect. What we do is just lateralize the tibialis anterior tendon laterally before we start treating for the ulcer. This is very common. The patient's coming with foot drop. You can see the right side, the patient is not having the normal gait pattern. The forefoot is touching the ground first. I follow the Srinivasan technique. Lately we modified the Srinivasan's technique where you are taking the tibialis anterior, circumtibially splitting into two and attaching to the tendons. And that is the movement of the toes we can see. Yeah. Our time is getting over. Then we go into the arthrodesis of the toe when there is excessive deformity, and that is the reason for the ulcer. The foot which has been in a cavovarus, which is the foot has been turned inside, we go for bony corrections, which is called as a triple arthrodesis. And this patient had wanted to wear a footwear, a shoe, long time now. So we have been able to correct his deformity and make him a footwear, shoe. We do get patients in the advanced stage where there is total destruction, and we have a rocker bottom foot. This is a rocker bottom foot, and we have a non-healing ulcer there on the foot lateral aspect. And if you see the X-ray, there's the X-ray which I showed you, there is a full mid-carpal collapse. So if you want to treat this ulcer first, now we need to understand what is the basic reason why the ulcer has happened. We have done a tendon lengthening. If you see there was a calcaneus deformity for that the tendoclis was lengthened. We have done the flap treatment, ulcer treatment by moving the medial calcaneal artery flap, and even the flexor digitorum brevis muscle was put to that area so that the bulk is added. And we could get the foot down to that level, and that is the pre-op X-ray picture. We don't have any calcaneal cuneiform bones there. We were able to push the metatarsal which was up there down to that level of the talus, so that the foot architecture itself has been transferred or brought back to the near normal stage. We do advise amputations for patients who are having intractable ulcers. And we are conservative in the line of amputations because most of the patients are from the poor, lower economic status, and they cannot use the prosthesis all the time. Advantage of this sort of amputations is that they can still manage without a prosthesis. This patient was a long non-healing ulcer which turned out to be a squamous cell carcinoma on biopsy. So we did a Symes amputation. Symes amputation advantage is the same, that the patient can still walk without a prosthesis, and if they want to wear a prosthesis, they have a Symes prosthesis. So to summarize, the treatment for the ulcer or the causality for the ulcer is multifactorial, and the treatment of the patients is individualized in long term, and the surgery and the treatment has to be a long term follow-up, and surgery does have a role in treating plantar ulcers of treatment. Whenever patient comes back with the ulcers, no, this is what I feel. Why God made us to walk with two upright, no. It would have been better we crawl. Or maybe we should train them to walk like this, so that their foot ulcers heal some way. Thank you very much.
Thank you, Dr. Latish, for that very practical lecture, and also congratulations for the great job. And also I would like to congratulate him because he has designed an instrument for the various measurements. When I went through his lecture, probably that could be the thing, that he has designed podometer, that is to measure for the measurements of foot, basically various measurements of foot. Thank you. Questions can be asked during the panel discussion time. And I thank the organizers for this honor.
Thank you, ma'am. May I request Dr. Balasaraswati to hand over the memento and certificate to Dr. Latish Latif. Thank you, ma'am. May I request Dr. Satish Bhai to hand over the certificate to Chairperson Dr. Balasaraswati. Thank you. Moving on to the next talk for the day by Dr. V.P. Shetty on advances in lab research in Hansen's disease. May I call upon Dr. Shrutakirti Shenoy to chair this session.
Good afternoon, everybody. Now we come to this very important talk, that is advances in laboratory research. Rapid strides have been made in the research laboratory investigations in leprosy. Laboratory techniques employed for the diagnosis of leprosy include Mitsuda intradermal reaction, skin smear microscopy, histopathology, serology, immunohistochemistry, PCR, imaging tests, electromyography, and blood tests. New tools currently available for specific cases or for research purposes include serological tests with phenolic glycolipid 1 antigen, that is PGL1, and protein antigens, immunohistochemical reaction with antibodies against BCG, PGL1 and S100 protein, polymerase chain reaction with several primers aiming at different genomic targets of M. leprae. Presently, the research priority is to identify molecular markers specific for M. leprae and develop sensitive laboratory tests to diagnose asymptomatic cases or those with few symptoms and to predict disease progression among exposed individuals, since early diagnosis and timely treatment are key elements to break the chain of leprosy transmission. And Dr. Pramod has already highlighted the notable achievements of our speaker, Dr. V.P. Shetty. And all in all, she's a very committed researcher in leprosy. Over to you, ma'am.
Thank you. Thank you, madam. You more or less covered summarized my presentation. And I would also want to say that we'll not be going into depth of each and techniques. I am also going to summarize as to what is being projected from the laboratory side, what is being done, and what are the key areas that are of some use to the clinical applications and in the field, and what can be developed, or what are the areas that have some scope in terms of early diagnosis, as Madam has